it's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
Yeah, so I've been at BJC about 11 years now, and it's a topic, remission, that's come up. It's more topical in the last sort of 5 years or so, or the latter half of my time at BJC, where there's increasing awareness about what we should be trying to achieve in treating people with rheumatology. And it's kind of come about because the drugs and medications today are so much better that we can actually try to achieve remission. So if you wind back the clock 20, 30 years, it was just not possible because the medications weren't there. And so just trying to keep the bare disease under control was the target back then, and preventing all the complications. So the bar's really changed in rheumatology. So we're going to go through how do we measure disease activity and remission. And I'm going to keep it broad because there's a few conditions that some people will have, and there's obviously a few conditions that we treat. So I'll try and keep it broad and use some examples along the way. What's the importance of remission? How do we, as rheumatologists, determine disease activity in remission? So how would we think about it? I'm going to talk about two concepts called treat to target and window of opportunity. You may have heard of these along the way. And that's really sort of concepts from the last 10 years of how we treat these days. And understanding that will help you understand why a rheumatologist is saying what they're saying. And I'm going to touch a little bit on medications and lifestyle, how we may improve disease activity to get you into remission. So very, very basics. When I explain autoimmune disease to someone, I explain that it's an overactive, inappropriate immune response against your own body. So if your normal immune system here is overactive, so people sometimes think when we give immune suppression, we're actually lowering the immune system too low. We're actually trying to lower it from a high point back to normal. And this immune system sets up chronic inflammation attacking the body. And depending on what disease you have in rheumatology, it will affect different areas. So it might affect your joints, your skin, in some people, the lungs and organs in more severe disease. And so that results in, I can't see the side of this here. Oh, there we are. Joint swelling and tenderness. And then you can also measure that on blood tests, where you see inflammation on blood tests with CRP and ESR. And so when we talk about disease activity, we mostly look at the last three boxes. So the symptoms people have, the signs that they have, like joint swelling and tenderness, and some laboratory measures. So that's kind of what I'll be talking about, because that's what a rheumatologist focuses on. We don't really have good tests to measure the immune response. So the immune response is very diverse. It's very, very hard to measure, except in like research laboratories. So there's no real test to measure deep down what your immune system is doing. We can only get very broad measures. And that's part of the problem in rheumatology, which makes it both a challenge and interesting, because there's so much challenge in measuring what's going on in people's body when they've got autoimmune disease. So disease activity is hard to measure, and that's because we can't actually measure really what we want to measure, which is what's going on deep down in the body, which is unlike some other conditions in medicine. And because of this, there's many different ways to measure it, and there's not really even agreements on the best way to do it. And so I'll present some of the different ways that it is measured in clinical trials, and it's very diverse and very complicated. And on top of that, you have different measures for different diseases. So the way you might measure someone's rheumatoid arthritis is different to lupus, because they affect different parts of the body, they affect different organs. Even the blood tests look different in those two diseases. And same with psoriatic arthritis. That'll affect people's bodies differently to rheumatoid arthritis. So you've got to measure different things to get an accurate measurement of what's going on. So a little bit about remission. So you're probably familiar with cancer remission. That's probably where it all started. What is remission? And basically, if you have a cancer and your doctor says you're in remission, it basically means they can't detect any sign of disease anywhere. There's no cancer that they can detect. Doesn't mean there's absolutely nothing, but they cannot detect anything. So all the scans, all the blood tests, there's nothing there. And if you get to that state, you're in remission. If you continue in remission, your long-term outcome from cancer is excellent. So the oncologist brought this whole concept up of remission. And I think one of the messages tonight is when we talk about remission in rheumatology, it does not mean a complete absence of disease. So it does not mean that you don't have any pain. You can still have some symptoms. You can still have some degree of limitation of function and still be in remission. So it's not a complete absence of symptoms. And partly this is because things like pain and stiffness can be due to many things other than active disease. And things like secondary arthritis on top, like from osteoarthritis or pain sensitization or fibromyalgia or muscle pain, they can all cause symptoms which feel like your disease is active, but it may not be the actual underlying rheumatic disease. So really a definition in rheumatology of what is remission is minimal or no symptoms or signs of disease activity and minimal evidence of ongoing inflammation. And I highlighted minimal because that's really the essence. It doesn't mean no symptoms. So when I see someone with, let's say, rheumatoid arthritis, and they come in and they've got some symptoms, okay? They might have pain, they might have stiffness. What I'm trying to think in my head is there symptoms due to ongoing inflammation from the rheumatic disease or rheumatoid arthritis or from other causes? Because if there's ongoing disease activity from inflammation, the treatment is really to get that immune system suppressed, get it down so it's functioning better and not causing that inflammation. But if the symptoms are due to other causes, I can change all of that all I like, and the person's not going to get better because their pain's been generated from other causes. So that's the first thing. And then even if I've determined, the rheumatoid arthritis is still a bit active and causing their symptoms, the second question is, well, is giving extra treatment, is this going to be safe or am I going to cause more problems than good? Because basically you can get rid of anyone's symptoms in rheumatoid arthritis, but you will cause side effects at some point. So there's this fine line to walk between causing side effects and not suppressing disease enough. And that's really, really the challenge. And it's also important to note that we talk about remission a lot. You might hear about remission, but for a lot of people I see, that may not be the target. So let's say if you're over 70 years old, for example, the aim of remission is to get minimal disease activity, and that's really to prevent future joint damage, future disability. But when you're over 70, for instance, I'm just picking on over 70, but you might have other medical problems that mean more medication is going to cause potential problems. And the aim is not necessarily to prevent joint damage 20 or 30 years down the track. The aim is to give good quality function so that people can do the things they want to do. And that's really where a discussion with your rheumatologist about what you actually want to be doing and what you can't do, because that can help guide some of the treatment. So the reason we talk about disease remission is because now we've got better medication, we can get to that in a chunk of people. And that results in a better quality of life and improved physical function. So less pain, less stiffness, better ability to do all the daily things, better ability to continue in work, do all the caregiving roles that you might have. And longer term, there's vastly reduced rates of joint damage and deformity. So the pictures you see on the internet of damaged joints and people really struggling to do things doesn't really apply to a lot of the times these days, because we can aim for so much better disease control that the damage doesn't happen. And a lot of the studies now are showing that if you get to remission, your life expectancy gets better. So just that prolonged inflammation in your body, not only does it make you physically less able, but it actually causes increased rates of cardiovascular disease, so increased rates of heart attacks and strokes. And so just by suppressing your disease better, you actually reduce heart attacks, you reduce strokes, and you improve life expectancy. So like everything is good about aiming for low disease activity. So this is where it gets complicated, and I've tried not to keep it too complicated, but I wanted to give you a feel of what it's like, how it's measured, not only in clinical trials, but in real world. So real world is really what your rheumatologist should be doing in the practice when they see you. Clinical trial, I've been doing quite a lot of clinical trials lately, and it's a very, very different setup. There's so many more measures that you take, and you often are doing clinical trials to prove that a medication or some other intervention is better than the standard of care. So you're really measuring everything to see if there's a difference. So it's a kind of a different way of thinking. And if you read papers, or I know some of you do a lot of reading on rheumatology, you'll see some of the terms I'll mention. They're really only done in a research setting because they're not practical in day-to-day practice. So this is not to overwhelm you. I'm not actually going to go through all of this, but let's just take rheumatoid arthritis. These are some of the measures that you'll see written in papers where they try to measure disease activity. So ACR's American College of Rheumatology, and they talk about 20% improvement, 50% improvement, 70% improvement. The DAS28, I'll go through a little bit in future because it's quite a common one. SDI, CDI, Boolean remission. You don't need to know about them, but rheumatologists talk about some of these things. Psoriatic arthritis, they try to measure different things in psoriatic arthritis because psoriatic arthritis affects the skin, it affects the enthesis, which is where tendons join bone. It can cause big fat fingers and toes called dactylitis, so that's measured, and it causes nail changes. So all of these different areas of disease can affect is measured in various scores because you're trying to see, does this intervention help the skin, or does it help the joints, or does it help both? To get a sense of what to expect when you're giving a medication to someone. And within these scores, there's multiple different domains to reach this score. So for instance, I'm going to use rheumatoid arthritis as an example. So ACR is one of the common ones. So American College of Rheumatology has been around for a long time. So what they're measuring in there is a combination of swollen joint count, tender joint count, and inflammation markers. So these inflammation markers are blood tests. And you'll probably notice that when you see a rheumatologist, they're probably doing that most visits. They're having a look at your joint and they're having a look at your inflammation markers. So they're sort of doing it in their head without necessarily doing it formally. They also use a couple of other points down here, but the CDI and SI, which is other measures, also use things like physician global meaning. Overall, what does the physician think on a score of 0 to 100? Where is this person going? And then a patient global is in a question for the patient from 0 to 100, how are you going? And 0 to 100, how's your pain? And then they do things like what's called a health assessment questionnaire, which is like 30 questions where they ask you, do you have difficulties, dressing, showering, walking, cutting food, all the daily activities. And then they put all these things in complicated formulas and come up with a score. And so this is how rheumatologists in trials measure to try and work out what's going on in the body. And rheumatologists can't even agree which is the best measure. But these are some of the measures. And just so you can see how complex it is, DAS activity, so disease activity score 28 means 28 joints, means you measure 28 joints. This is the formula. And this is one of the easiest ones. So you're trying to measure how many tender joints does that person have? How many swollen joints do they have? What's their CRP, which is a blood test? And then a VAS global is how is the person feeling? And then you put it into this really complicated formula and come out with a number. And then that number will tell you how that person's doing. So if it's below 2.6, they're officially in remission. And so you'll see clinical papers talk about, oh, DAS28 remission was achieved in a certain number of people, and that's how effective the medication is worked. But you can see why this is not done in day-to-day practice. This is the easiest one of the lot, and it's very complicated. So, but I mean, in our practice at BJC, our practice software has this formula in there. You can calculate it relatively quickly, and some rheumatologists do. So it may not be as complicated as I'm presenting, but this is how a rheumatologist would try and determine how you're going. And then to confuse things even more, you've got things like ankylosing spondylitis and lupus, and they have a whole lot of different acronyms, whole lot of different measures. So for ankylosing spondylitis, you're measuring things like their spine a lot more, like the stiffness in their spine. You're measuring their movement, which is the metrology. You're also measuring the enthesitis, which is the tender points around the body from inflammation. And you're measuring the F here, the BASF is about function. And then with lupus is the most complicated one of the lot, because that can affect virtually any organ in the body. So it can affect the skin, it can affect the heart, it can affect the lungs, it can affect blood counts, it can affect the joints, it can affect the hair. And so you got measures for almost everything. And even this SLEDAI and BILAG has 100 questions in it. So these are really complicated scoring systems that are thought to be the best we have. And people still can't agree which of these is used. So often a clinical trial will measure all of this. So it's not practical in day-to-day, when seeing people to do any of these measures. So you've got to have a sort of a system to try and work out from what your understanding is, how to apply that to each person that you're seeing. So as I've alluded to many times, most rheumatologists don't use these formal calculations, but most rheumatologists would be doing some vague assessment in their head using a combination of joint count assessment, which is why a rheumatologist is often feeling your joints. So when people ask me, why are you feeling my joints every time? So what we're feeling for is the joint sore and is it swollen? So when we're feeling an enlarged joint, we're trying to assess, is the joint bony enlargement or is it soft tissue? So it's spongy. And inflammation is usually soft and spongy. And any of you who've suffered inflammation will probably be able to tell the difference. But that's what a rheumatologist is feeling for. So you can combine a rough assessment of your examination with roughly the inflammation markers on the blood test, which is why you're usually asked to do a blood test before seeing your rheumatologist. And then a vague question of how you're going, how's your pain, what joints are troubling you, that sort of line of questioning to get an idea of your symptoms. As I said, some rheumatologists will use that DAS-28 score that I talked about, but there wouldn't be many that I know of that do that routinely on every patient, just because it's too complicated all the time. And those formal scoring systems that I talked about really are clinical trials to assess effectiveness, to give really hard measurements so we know, what the medication does and doesn't do. So now that I've given you and confused you all about disease activity, I'm going to talk a bit about treat to target. And treat to target is, again, probably what your rheumatologist is doing, whether it's communicated to you or not, or I hope your rheumatologist is considering doing this. And that is that we're trying to achieve a target, which may be our target for treating your rheumatoid arthritis is in remission, or it may just be treating low disease activity, but you've got some idea in your head about what you're trying to achieve for that person. And so treating to a target, just in the left box, occurs all the time in medicine. Again, whether you know it or not, but your blood pressure, there's a target of what you might treat a blood pressure to. 130 on 90 might be a common one, could be even lower for certain diseases, but you're trying to get a blood pressure below a certain point. Your diabetes, you're trying to get your HbA1c, which is a 3-month measure of your blood sugar, below a certain point. And your cholesterol, your LDL, your bad cholesterol below a point. And the only one in rheumatology where there's really strong agreement is probably gout, which is if you treat your uric acid below 0.36, you'll have good outcomes. And the reason these targets are chosen is because there's very, very, very good evidence that if you get to these targets, you'll prevent what you're trying to prevent. So for diabetes, you're going to prevent them getting a heart attack. You're going to prevent, getting nerve damage and eye damage. And cholesterol, if you get it below a certain target, your chances of a heart attack drop dramatically. And gout, if you persistently keep uric acid below 0.36, you basically don't get gout. So these are very well established. The principle of all of this is that you agree on a target, which might be disease remission. You use some sort of system to try and measure it, and you have regular reviews and alteration of treatment until you get to that target. And that's why rheumatologists often fairly early on will talk about medication, because you're trying to get that inflammation down to a level early on and get to that target, because treating to target has been shown to have better outcomes in the long term than just standard of care, like just doing what you've normally done. So you get far better long-term results. And so basically, if you're not at your target, you change treatment to get to that target, and you keep reassessing until you get to that target. And the whole point of it is you try to individualize the treatment plan for that individual to try to get to that target. And this sort of flows on to what's called the window of opportunity. And this is, again, why a rheumatologist will very quickly or very early on talk to you about medication to get things under control, not just to make you better, but because it results in much better long-term outcomes and ultimately often less medication. Although it may not feel like it early on, but ultimately there usually is. And the premise here is that when you don't have, when you have early disease, so you don't have too many symptoms, there's not too much immune pathways that are wrong in the body. But what happens with most autoimmune diseases, the longer you leave it inflamed, the more and more and more and more different parts of the immune system become active. So if you treat early, you've only got one little part to try and suppress. Over time, if lots of different parts are active, you're going to have to use a much broader range of treatments to try and get that under control. So not only does it result in better outcomes in the short term, but in the long term, it's better, and it results in higher rates of remission. So some of the best people I've treated for rheumatoid are people who've actually gone from having symptoms to seeing their GP, to getting in to see a rheumatologist, to getting on medication in a very short space of time, not having problems with the medication, responding beautifully. It's like night and day, some of the difference. It's like some of these people have nothing, no symptoms whatsoever. That's the best results by far. So a lot of what we try and do, why we try and get referrals in, is we can have a look and see, does this look like there's inflammation? Do we need to see this person quicker? And we try and adjust our lists to see people quicker if we think that's it, because we know we can make a difference earlier on. And that if you leave it and leave it and leave it and leave it and leave it, you'll get more medication on board and you'll have poorer outcomes in the long run. So that's pretty much unequivocal. So it's best studied in rheumatoid arthritis, but people always say, oh, what's the best time to get on treatment? And it's not exactly clear, but it's probably within the first 6 to 12 months of symptoms. So it's not within, the first, 20 days of symptoms. It's not that early, but you don't want to leave it and leave it and leave it. And some people procrastinate about taking medication until it gets really, really, really bad. And that's not the best outcomes. We know that pretty unequivocally from all the research. So how do we aim for getting people in remission or low disease activity? Well, there's the two broad areas, pharmacological or medicine, and non-pharmacological or lifestyle factors, which I'm sure you've heard a lot about other people talking. I'm only briefly going to go through this, but broadly speaking, we break medication down into conventional medications or synthetic medications and what's called specialized or biologic medication. And a very simple way of thinking of this is the conventional medicines are always used first, in Australia at least. There's a few reasons. One is they've been around for a very, very long time. Two is we know their long-term safety is good. Three, they often work for a percentage of people. And four, they're actually really cheap for the government and for the patient. And so given that they work in a lot of people, they're usually chosen first because they're cheap. Now, the specialized or biologic medication, you may have seen some of these names for people that have attended a few talks, or maybe you're on some of these medication, but these ones basically have come about from a lot of research in rheumatology, working out what underlying in the immune system is going wrong, and making a medication that specifically targets that part of the immune system that's going wrong. So they're very specific medications and often have less side effects than the conventional ones because they're very targeted. And so these are, I guess, the new age medicines, and they're more effective than the conventional. So people have started off with the conventional. If they're not working, a second one will be added. And if that's not working, you usually progress to the specialized or biologic medication. The conventional medications, my simple explanation between the differences, if you think of the immune system as like a 10-lane highway with cars barreling along it, the conventional medications, it's almost like they slow every lane down. So you're suppressing everything a little bit, all 10 lanes. Whereas the specialized medications, the biologics, instead of blocking all 10 lanes, they just block one lane. Okay, completely block one lane. The other 9 lanes are still functioning. And that's why you can completely block one part of the immune system and people don't fall in a big heap because everything else is working normally. And so we classify them by what part of the immune system is being treated. So the TNF inhibitors block a molecule called TNF. Tocilizumab blocks a molecule called interleukin-6. The JAK inhibitors block a molecule called JAK, and IL-17 block a molecule called IL-17. The bottom two, IL-17 and 23, for instance, work in psoriasis and psoriatic arthritis and often ankylosing spondylitis, but they have no effect in rheumatoid arthritis. So we've learned that different parts of the immune system are causing different problems in each individual. And with rheumatology, every individual that we'll see may have different parts of the immune system, slightly different parts of the immune system that's going wrong. And that's why one person may get a fantastic response to a TNF inhibitor and the next person doesn't really work for. And then another person may respond beautifully to a JAK inhibitor, but the TNF inhibitor didn't work for them because each person, what's going on deep within their body is different. It's just that we can't measure what's going on. So it's a little bit of guesswork as to which one we would choose. And so it might surprise you how low some of these figures are. It's like how much remission do we get with medication? And so the conventional ones like methotrexate and leflunomide, it's in the ballpark of 20 to 30%. So it's not huge. It's probably higher than that when you treat people early in the window of opportunity, like it might be up towards 50% if you get people early on. But when they do a lot of studies, certainly in disease that's been there for a while, it's only 20 to 30%. And that's why people often need more than one medication. The specialized or biologics are sort of in the order of 30 to 50%. So there's still a huge chunk of people that don't get to remission, which is really low disease activity. So they might still be going okay, but they're not really good. But when studies have been done where they look at early treatment or milder disease, you're getting scores 60, 70, 80% much higher rates of remission. So that's why we try and get people in early, because your rates of remission are much higher earlier on. And so most rheumatologists will, by treating to target, be cycling through medications quickly to try and get into remission and get the better treatments in early if needed. So I've said the above figures are from clinical trials and real world responses are probably different. Now, that's probably because in clinical trials, you're often selecting people that are not doing particularly well. And bear in mind, clinical trials often come from all over the world. So a lot of Eastern Europe or Asia where they don't have access to medicines like we do here or access to healthcare. So you're getting people at different stages of disease and you're just putting them all together and trying to get outcomes. So it may not apply to the Australian healthcare system where we have better earlier access to specialist care and specialist medicines. And so why don't we get better rates of remission? And even with all the medications that cost thousands of dollars, and that's really because I think a few factors, but one is the complexity of autoimmune disease. We can't measure deep down really what's going on in an individual. Maybe in future we can, but now we can't. So we're not guessing. Guessing's the wrong word, but we're trying to make educated, responses as to how someone's going and treat from there. But then there's also problems. People present late. There may be medication intolerances, which just mean you have to keep trying different medications till you find one that works. And Comorbid disease means people have other health issues, which means you're really limited in your medication because you can cause too many problems by treating too aggressively. So you're kind of limited in how you can treat an individual. And that's, I would say over time, these remission rates are going up and up and up, but there's going to be a ceiling, even with really good medications.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events and access our team of facilitators live. All of the details that you need to join BJC Connect are now flashing up on your screen. Otherwise, like our staff, subscribe if you'd like to see more information from BJC Health. Look forward to seeing you in an event soon.